How do you handle Group B strep testing and treatment? Are there any alternatives? What is the best way to minimize the risk of infection during delivery? Great question. And this is something that midwives and parents have to tackle every pregnancy, because status can change between pregnancies, and it also changes depending on flora and fauna in the person's body. So Group B strep is a bacteria that lives in our mid-colon. It's considered to be at an overgrowth when it can be cultured in the urine, in the vagina, or in the rectum. And that status can change every 3 to 4 days. In the United States, we do universal screening, which means everyone is encouraged to be screened between 35 and 37 weeks. And then based on those results, we either treat them as positive or negative. Folks who are negative don't need any treatment, and folks who are positive are encouraged to have the CDC antibiotic regimen, which is IV antibiotics every 4 hours in active labor. And there's obviously some questions with this. First of all, how often the GBS status can change in a person. Second of all, the risks of repeat or unnecessary antibiotic exposure. So lots to debate there. Where I practice in India, we do risk-based treatment. So there's no screening at all, and folks who have the risks are treated. So that would be like a fever in labor, a preterm baby with GBS disease, or it could be prolonged rupture of membrane, and those folks get treated. The risk of GBS infection is actually quite low, but the problem is that the GBS bacteria is very virulent, so it colonizes the new land called baby very quickly, and that baby with a very immature immune system will be quickly overwhelmed. So very few babies do get infected, but the babies that do get very, very sick. And the theory is that if we get antibiotics in the mom before the birth, we will have much less infections, much less, the baby will be less likely to be overwhelmed by that. So that is kind of the overview. The question here is, how do we handle testing and treatment? And if we're talking about OBs or midwives, CNMs, CPMs, I do recommend that you offer treatment according to the CDC protocol. And that's because it's defensive. The client can, of course, decline. We should always have informed decision-making processes and documents that allow them to opt out of standard of care. But we would be remiss if we didn't offer it. So that's an important step. And in terms of alternatives, there are no evidence-based alternatives that I know of preventing or treating GBS. There's lots of theories, garlic and Hebiclins and fermented veg and all kinds of things. So I would never discourage anyone from doing what they think is best, including using alternatives, but I can't necessarily recommend them. GBS is a complicated subject, and I think it's very reasonable for folks to opt out of universal screening and instead use risk-based treatment, where we only get the antibiotics if we obviously have a risk of infection, like prolonged rupture of membrane.